Hi, everybody. I'm Nick Morley. I'm a PGY3 EMIM resident, and this is going to be a turn back in time to about a week ago when we were doing pre-hospital. I was originally scheduled then, but I got bumped to now. So we're going to start with a little story. This is based on a real case from June 2022. So let's say you're walking down Mott Avenue in Far Rockaway. You spent the day at a beach. You had a great time. It's the summer. It's beautiful out, and you're just making your way back to the A train to start the long public transport journey home. Let me see. How does this go? There we go. Okay, so down the block in front of you, a black SUV stops partway through turning a corner. The window rolls down and you hear 5 gunshots in quick succession. The window rolls up and the SUV drives away. 2 people lay on the street. One is a young man grasping his left arm and screaming that he's been shot. Another is a young woman who's holding onto her right lateral chest. The woman isn't talking, but is awake and breathing slowly, though she seems anxious. So before you can finish a full primary survey, another car pulls up and a stranger gets out. I just saw what happened. Let's get both of them to the hospital right now. Just get them in my car. Another bystander interrupts him. We gotta wait for the ambulance, all right? They know what they're doing. The man on the ground yells that he's not getting in any cop cars today, and he starts getting up to leave. So you identify yourself as an emergency physician, and now let's get a show of hands. What do you suggest they do? Do you go in the private vehicle or do you wait for EMS? Private vehicle, hands. Jamaica is close, like it's 20 minutes. All right, so again, private vehicles, hands. Okay, EMS. Okay, so it looks like mostly EMS. So this is my talk, Penetrating Insights. It is a paper discussion based on a paper that I found from 2017 that looks at this very problem, that in fact suggests that private vehicles may have a mortality benefit over EMS for penetrating trauma. So this is with thanks to the Small Talks team of Drs. Beck-Esme, Buckridge, Croney, Davila, Dukas, and Willis. Okay, so say you tell the gathered people, let's wait for EMS, all right? Maybe this lady has a tension pneumo. You want to wait for somebody who has a needle to decompress it. This is from the protocols of EMS on how they approach and how they're supposed to approach penetrating trauma, general trauma, any trauma whatsoever. Number 1, you control external bleeding. Maybe you do some spine immobilization if you're concerned about a spinal injury. If you're an EMT, you can also stabilize potentially unstable pelvic fractures with either clothes or a pelvic binder. And then if you're a paramedic, you can do a needle decompression. That's, difference between ALS and BLS here. ALS, they can do that decompression, BLS cannot. But overall, their strategy for trauma in general is going to be scoop and scoot, not stay and play. They want to get somebody to the hospital as soon as possible because of the phenomenon known as the golden hour for trauma, where you have about an hour before mortality becomes much greater likelihood in penetrating trauma. So in that sense, maybe any vehicle that is right next to the actual incident would be better than an EMS, even without any treatment. So how does EMS versus private vehicle affect mortality and penetrating injuries is the sort of question animating this study, the association of pre-hospital mode of transport with mortality and penetrating trauma. So it's a large, retrospective, observational study from 2017. Let's dig into it. So basically, the study aimed to take a population-level look at urban healthcare systems, the 100 most populated trauma systems. So they based this on prior research that showed smaller studies, usually 1, 2, or 3 trauma centers, that suggested that maybe EMS was associated with worse survival rates than private vehicles for penetrating trauma, even without treatment. So they wanted to scale this up. They wanted to look at the largest database they could find on trauma cases and see if the mode of transportation from the area still was associated with a mortality benefit for private vehicles. So again, since it's retrospective and observational, the cases have already happened. There's no randomization here, and we're not actually able to discern causality. This is only going to be association. So the independent variable here being transport. And they want to find out if it's, better for the ambulance, or if I can go over here, better to do this. All right. So what they used was the National Trauma Data Bank. So this is a proprietary data bank owned by the American College of Surgeons that is the largest single trauma database in existence, they claim. I'm not sure if that's correct, but it's quite large. They collected data from January 2010 to December 2012. They looked at gunshot wounds and stab wounds. Age had to be greater than 16. They looked at only level 1 or 2 trauma centers. They did not look at transfers, importantly. They also looked at the 100 most populated trauma centers and then split them up by quartile for most populated. They looked in deaths in the ED and also in the hospital. That was the main outcome measure. And they looked at confounders such as population density, the type of trauma center, the injury severity score, and the GCS score on arrival to the emergency department. The data was analyzed using a t-test and chi-squared test. Where is this? And this is just me looking at all of the data here. Okay, so this is their flow chart for selection. They had initially over 2.3 million cases from 869 hospitals. A number were excluded based on age, injury mechanism, transfer, and incomplete records for mortality. And then more were excluded due to transport mode, not ground emergency medical service or private vehicle. I think that's important to mention because they did not look at walk-ins. They did not look at air transport. Then they were excluded, 33,000 more were excluded because the trauma center was not urban or level 1 or 2. And that left us with a total N of 103,029 patients from 298 hospitals. Of these, 10,364 died. And then we break down what type of transport was associated with those deaths. So if you look here, you can see unadjusted mortality was lower for private vehicle transport than ground EMS, 378 deaths in private vehicle versus 9,986 with a significant P of less than 0.001. Now that was quite surprising to me, and still private vehicle transport was associated with lower unadjusted rate of death in the ED compared with ground EMS transport. So looking at it on its face, it doesn't really make sense. Shouldn't the EMS be able to get people faster with the lights and sirens, provide treatment? But, looking at even with adjustments based on the confounders that they analyzed, there is still a significant mortality benefit for both gunshot wounds and stab wounds in private vehicle transport versus EMS here. So let's pump the brakes a bit and think about downsides of this study. What are some possible things that could be influencing this result? Anybody have any? Throw stuff out. Shane.
Probably a selection bias. If I'm driving around in a car, I'm much more willing to probably drive somebody who can hop in the back as opposed to somebody just bleeding out on the street. And so you're more likely to be picked by EMS.
Absolutely. Absolutely. Exactly. Alice, same thought. Anybody else? Other thoughts? No. Okay. So number one, absolutely selection bias the authors talk about. So this is a huge issue with working with retrospective data because you're not able to properly randomize. You're not going to be able to control for all of the possible variables that go into the sample that you're taking from the target population. So, for example, like you said, maybe just because of the fact of the severity of injury, you're going to have to go with EMS. Maybe you were already going to die, more likely, based on the fact that you're getting EMS transport. The way that you would get rid of this, solve this, would be to do, randomization, an RCT. But given the ethical considerations for this type of study, I don't think an IRB is going to be approving that anytime soon. Okay, Number two is low numbers in certain subgroups. So as you saw in the previous one, there was only 39 deaths in the gunshot wound for private transport. And, even though that's a small percentage of the overall size of the private transport group, which was about 17,000, that still can skew the results. This still might not be a big enough sample to accurately capture what is actually happening between these two. And this is the, David Goliath situation here. And then number three is missing data. So one of the things that they mention in the paper is that they did not have time of travel for basically any of these cases. So we do not actually know how long EMS or the private vehicle was traveling. And understandably, that can be a bit difficult to obtain. So maybe there was some sort of road rage situation that kept EMS from getting there on time, or the private vehicles, when you were doing a private vehicle, maybe it was late at night and the roads are empty. We don't have the data to say that. So these could be things that are still affecting these results. But even with all that said, the authors still said that this mortality benefit holds true on subgroup analyses of the 100 most populous U.S. trauma systems. They think that the current paradigm of waiting for an ambulance to come for a penetrating trauma is not optimal care and represents a need to change current protocols to allow for private vehicle transportation in order to get to a level 1 or 2 trauma center as soon as possible for optimal outcomes. So this had me looking like this, and it had me asking, what now? Is this happening? Has there been any change? This is kind of an old paper. It's from 2017. Short answer is no, nothing's changed. The most recent penetrating trauma public information campaign is Stop the Bleed. This was a campaign created by the American College of Surgeons in collaboration with the United States military based on the experiences of basically field hospitals in Iraq and Afghanistan. It was released in 2014 and has these four simple steps: apply pressure, apply dressing and press, and then if still bleeding, apply a tourniquet, and instructions for applying a tourniquet. At the end of that is always call 911. Still, I just spent yesterday over at telemetry for FDNY, so I checked with them about this. The protocol for penetrating injury is still to recommend waiting for an ambulance. So unless there is none readily available and everything is backed up. So let's say, has there been any sort of stresses on the medical system recently that maybe made it difficult to get an ambulance, or maybe a bunch of other infected patients were at the hospital and sort of keeping resources tied up, a kind of natural experiment, if you will? Why, yes. So I think the future of penetrating trauma pre-hospital care may be in the past. There is this study from 2023 that is in the Journal of Surgical Resuscitation, which looked at this very question. They saw, basically anecdotally, an increase in private transport for all trauma during the COVID pandemic because of the stay-in-place order and because of the stretch on resources pre-hospital. They took a look at the year before the pandemic, transport to and from the hospital and mortality rates, and then the year after. The type of transport to and from hospital and mortality rates as well. So what effect did they find? So they looked at 11,919 adult trauma patients. 75.7% of them were in the pre-pandemic, and then 24.3% were in the post or pandemic group. As you can see, there's a bit of an imbalance, and I think that's one of the weaknesses of this paper, is that they just don't have comparable patient numbers between the two. With that being said, the rates of penetrating trauma as a proportion of these two groups, penetrating trauma went up, and then private transportation also went up, not by much, but it's still a significant increase compared to before the pandemic. The authors found there was no difference in mortality for all trauma in those two time periods, even though there was an increased rate of penetrating trauma, usually more deadly than blunt, and an increase in ground transportation, private ground transportation for these things. They do. They included police vehicles as private transportation. That was, put in. They did in in the appendix, they have a subgroup analysis on police transport versus like truly private vehicle transport, and they found no significant difference between the two. So they included it in the private vehicle group. Okay. So this isn't moving, but that's fine. So their conclusions, they found that there was a trend toward private transportation during the shelter-in-place phase. However, this did not coincide with a change in mortality. There was a downward trend in mortality overall. I think that might be attributed to the total number of patients for trauma being lower during that time because nobody was really driving. But they did note it nonetheless. It wasn't a significant trend. I think that this is also evidence that maybe there is something there, that there is maybe a unexploited possibility for EMS to utilize private transport to try and improve mortality for these penetrating trauma patients in their protocols going forward. And maybe we could all go to the hospital like this. All right. Thoughts, questions?